Good morning. My name is Anthony Whitney, and I appreciate the opportunity to present my Doctor of Nursing Practice Quality Improvement Project titled Interpreter Facilitated Diabetes Education for Limited English Proficient Patients, a Quality Improvement Initiative. This project was completed at the Culinary Health Center Convenience Care Clinic in Las Vegas, Nevada. It focused on improving diabetes outcome among Spanish-speaking patients with limited English proficiency by implementing a standardized diabetes education program delivered with professional medical interpreter services. First, I'd like to thank my wonderful chair, Dr. Elizabeth Merritt, the Nursing 705 faculty, and my committee member, Miranda Olging, for their guidance and support throughout this project. Before discussing the project itself, I'd like you to think about the experiences from the perspective of our patients. Imagine being told you have diabetes, a chronic condition that you'll manage for the rest of your life. You're given new medications. You're told to change your diet, check your blood sugar, exercise daily, schedule follow-up appointments, learn to recognize the signs of hypoglycemia. Now, imagine receiving all of these instructions in a language you don't fully understand. For many patients with limited English proficiency, this is their reality. At the Culinary Health Center, I care for many Spanish-speaking patients every day. Although professional services are available, I recognize that diabetes education varies from one provider to another, creating opportunities for inconsistent education and misunderstanding. That observation became the foundation of this quality improvement project. Once I recognized this practice gap, the next step was to determine whether the evidence supported implementing standardized approach to interpreter-facilitated diabetes education. Diabetes is one of the most common chronic diseases managed in primary care, and successful treatment depends heavily on patient understanding. Patients must understand how to take the medication correctly, monitor their blood glucose, make dietary changes, recognize complications, and attend their regular follow-up appointments. For patients with limited English proficiency, these responsibilities become even more challenging when language barriers interfere with communication. Even when professional interpreter services are available, the quality and consistency of diabetes education can vary amongst providers. At the Culinary Health Center Convenience Care Clinic, I frequently cared for Spanish-speaking patients who relied on professional interpreter services during their visits. Although interpreters help bridge the language gap, there was no standardized process to ensure every patient consistently received the same education-based, culturally responsive diabetes education. Organizational data further demonstrate the need for the improvement. Of the 2,528 established patients with type 2 diabetes, 785, approximately 31%, had a hemoglobin A1C of 9% or greater, indicating a significant population with poorly controlled diabetes. These findings highlighted the opportunity to improve both consistency of patient education and diabetes outcomes through standardized interpreter-facilitated educational program. Recognizing this practice gap led me to ask an important question. What does the evidence tell us about improving diabetes outcomes for patients with limited English proficiency? Before implementing the Quality Improvement Initiative, it was important to determine whether the current evidence supported a standardized approach for diabetes education for patients with limited English proficiency. The literature consistently identified three key themes that guided this project. First, professional medical interpreter services improved communication between providers and patients with limited English proficiency. Edwards and colleagues demonstrated that interpreters supported Spanish language diabetes education improved glycemic control, and reinforced the importance of communicating health information in a patient's preferred language. Second, the standardized diabetes self-management education was recognized as a cornerstone of evidence-based diabetes care. The American Diabetes Association Standards of Care recommended that diabetes education be individualized, culturally responsive, and reinforced throughout the continuum of care. Research has shown that these educational interventions can improve self-management behaviors such as reduction in hemoglobin A1C by as much as 0.6 to 1.7%. Finally, the literature emphasized the importance of culturally responsive care. Hong and colleagues found that patient-centered communication strategies, including teach-back method, improve patient understanding, engagement, and self-management. These findings reinforce the importance of not only translating information, but also ensuring patients truly understood how to manage their diabetes. Collectively, these findings provided a strong evidence base for implementing a standardized interpreter-facilitated diabetes education program in my clinical setting. After establishing that the literature strongly supported the intervention, the next step was to select a framework that guided implementation and sustainability of a practice change. To guide implementation of this quality improvement initiative, I used Lewin's change theory, which provided a practical framework for planning, implementing, and sustaining practical change. During the unfreezing phase, I identified a practice gap within the Culinary Health Center. Although professional interpreter services were available, there was no standardized process to ensure that patients with limited English proficiency consistently received evidence-based diabetes education. This created a variation in patient education and opportunities for misunderstandings related to diabetes self-management. The change phase focused on implementing the intervention. Providers delivered standardized, culturally responsive diabetes education using professional medical interpreter services. The educational toolkit emphasized medication adherence, blood glucose monitoring, healthy lifestyle behaviors, recognition of hypoglycemia, and the teach-back method to confirm patient understanding. Finally, during the refreezing phase, the standardized education process was incorporated into routine clinical workflow by using existing interpreter services, educational materials, and documentation practices. The intervention became sustainable without requiring additional staff or other resources. Overall, Lewin's change theory provided a structured approach that helped translate evidence into a sustainable improvement in clinical practice. With the implementation framework established, I'll now describe the project design and quality improvement methods that were used to evaluate the effectiveness of this intervention. The project used a pre- and post-intervention quality improvement design to evaluate the effectiveness of standardized interpreter-facilitated diabetes education program. The project was conducted at the Culinary Health Center Convenience Care Clinic in Las Vegas, Nevada, where I provide care to a large population of Spanish-speaking patients with type 2 diabetes. The target population included adult patients with limited English proficiency who require professional medical interpreter services during their clinic visits. The intervention consisted of standardized, culturally responsive diabetes education delivered through professional medical interpreters during routine patient encounters. Educational topics include medication adherence, blood glucose monitoring, healthy nutrition, physical activity recognition of hypoglycemia, and the teach-back method to confirm patient understanding. To evaluate the effectiveness of the intervention, I performed retrospective chart review comparing patients' hemoglobin A1C values before the educational intervention with follow-up hemoglobin A1C values obtained approximately 8 weeks later. The primary outcome was the change in hemoglobin A1C following implementation of the standardized education program. Now that I've described the overall project design, I'd like to discuss the participants who were included in the intervention they received. Eligible participants, including adults 18 years of age and older with type 2 diabetes who require professional medical interpreter services during their clinic visits. To ensure consistency, participants also had a baseline hemoglobin A1C between 6.5 and 10% and received the completed standardized educational intervention. Patients were excluded if English was their primary language, if they were pregnant, had end-stage renal disease, significant liver disease, or did not receive interpreter-supported education. A consecutive sampling approach was used, meaning every patient who met the inclusion criteria during the implementation period was included in the project. This approach reflected the routine clinical practice and helped minimize selection bias. The intervention itself was designed to be both standardized and culturally responsive during routine clinical visits. Professional medical interpreters facilitated diabetes education covering medication adherence, blood glucose monitoring, nutrition, physical activity, and recognition of hypoglycemia. To improve patient understanding, education was tailored to each participant's preferred language and included culturally relevant dietary discussions along with the teach-back method, allowing patients to explain key concepts in their own words. Follow-up hemoglobin A1C testing was obtained approximately 8 weeks after intervention to evaluate changes in glycemic control. After implementing these interventions, the next step was determining how to ensure its effectiveness. I'll now discuss the data collection process and the statistical analysis used to evaluate project outcomes. Project outcomes were evaluated through retrospective chart review of Athena electronic medical records. Data collected included baseline hemoglobin A1C values obtained before the intervention, follow-up hemoglobin A1C values collected approximately 8 weeks after the educational encounter, documentation of interpreter utilization, and completion of the recommended follow-up laboratory testing. To protect patient confidentiality, all data was de-identified and entered into a secure password-protected database using unique study identification numbers. Descriptive statistics were used to summarize participants' characteristics, including age, gender, and follow-up completion rates. These statistics provided an overall description of the project sample. To evaluate the effectiveness of the intervention, I selected pair sample t-testing because hemoglobin A1C measurements were collected from the same participants before and after the intervention. This statistical test was appropriate for determining whether the standardized interpretation facilitated diabetes education program resulted in significant change in glycemic control. The primary outcome of interest was a change in hemoglobin A1C following implementation of the intervention. Now that we've discussed how the project was designed and how outcomes are measured, I'd like to describe the participants who made up the project sample. A total of 20 participants met the inclusion criteria and received the standardized interpreter-facilitated diabetes education intervention. Of those participants, 17 completed the follow-up hemoglobin A1C approximately 8 weeks after their educational encounter, resulting in an 85% follow-up completion rate. I believe this high follow-up rate reflects the strong patient engagement and demonstrates that the intervention was well integrated into routine clinical practice. The average participant's age was 57.3 years, and the sample included an equal distribution of males and females with 10 participants in each group. Eligible participants were adults with type 2 diabetes who required professional medical interpreter services during clinical encounters. By using clear, defined inclusion criteria and consecutive sampling approach, the project reflected routine clinical practice while minimizing selection bias. Although the sample size was modest, it provided significant data to evaluate the effectiveness of the intervention and identify meaningful changes in glycemic control. With the participants' characteristics established, the next question was whether the intervention actually improved glycemic control. The primary outcome of this quality improvement project was the change in hemoglobin A1C following the implementation of the standardized interpreter-facilitated diabetes education program. As shown in the graph, the hemoglobin A1C decreased from 8.01% before the intervention and 6.89% after the intervention, representing on an average reduction of 1.11 percentage points. Statistic analysis demonstrated that the improvement was highly significant, with the paired t-test yielding a p-value of less than 0.1. From a clinical perspective, this reduction is particularly important because improved glycemic control is associated with lower risk of diabetes-related complications and better long-term patient outcomes. Overall, these findings demonstrates that implementing standardized interpreter-facilitated diabetes education was associated with meaningful improvements in glycemic control among adults with limited English proficiency. While the reduction in hemoglobin A1C represents the primary outcome of the project, several additional findings further support the effectiveness and feasibility of the intervention. First, 85% of the participants completed the follow-up hemoglobin A1C testing approximately 8 weeks after the educational intervention. This high follow-up reflects strong patient engagement and suggests that participants remain actively involved in their diabetes management. Second, the standardized interpreter-facilitated diabetes education program was successfully incorporated into existing workflow at the Culinary Health Center without disrupting routine patient care. Providers were able to deliver consistent evidence-based education using processes that were already available within the organization. Importantly, implementation did not require additional personnel, specialized equipment, or significant financial investment because the project leveraged existing interpreter services, education materials, and the electronic medical record. Finally, no adverse events or unintended consequences were identified during the implementation. Collectively, these findings demonstrated that the intervention was not only effective but also feasible, sustainable, and well suited for integration into everyday clinical practice. Although these findings were encouraging, it's also important to recognize limitations of the project when implementing the results and considering future implementation. Although the project demonstrated positive outcomes, several limitations should be considered when interpreting the findings. First, the project included a relatively small group of 20 participants and was conducted in a single outpatient clinic. As a result, the findings may not be generalized to large or more diverse populations. Second, follow-up hemoglobin A1C measures were obtained approximately 8 weeks after intervention. While this time frame allowed evaluation of short-term improvements in glycemic control, it does not provide information about long-term sustainability for the intervention. Third, the project primarily included Spanish-speaking patients with limited English proficiency. Additional research is needed to determine whether similar outcomes would be achieved with other linguistic and cultural populations. Finally, although professional interpreter services were already available within my organization, not all healthcare settings have access to these resources. The cost of establishing or expanding professional interpreter services may increase barriers for organizations with limited financial resources. Further implementation efforts should be considered resource availability when adapting this intervention to different practice settings. Despite these limitations, the project demonstrated meaningful improvements in glycemic control while showing the standardized interpreter-facilitated diabetes education can be successfully integrated into routine clinical practice when appropriate resources are available. Recognizing these limitations provides important context for interpreting the findings. Even with these considerations, the project demonstrated meaningful improvements in glycemic control and highlighted potential impact of standardized interpretation-facilitated diabetes education. Next, I'd like to discuss and explain what these findings mean. The findings of the project indicate that standardized facilitated diabetes education was associated with meaningful improvements in glycemic control among adults with limited English proficiency. The statistically significant reduction in hemoglobin A1C suggests that improving communication through professional medical interpreters and standardized education can positively influence diabetes self-management. These findings answer the primary question of this project by addressing language barriers, improve short-term glycemic controls. Ultimately, these findings suggest that when patients clearly understand their disease and treatment plan in their preferred language, they are better equipped to successfully manage their chronic medical condition. The findings of this project are consistent with previous research supporting culturally responsive diabetes education and professional medical interpreter services. Similar to the American Diabetes Association's recommendations, the project demonstrated that standardized diabetes self-management education can improve glycemic outcomes when delivered in a culturally responsive manner. In addition, this project supports Hong and colleagues' findings that patient-centered communication strategies, including the teach-back method, improve patient understanding and engagement. While this was a quality improvement initiative conducted in a single organization, the consistency between these findings and the existing literature strengthens confidence in the effective standardization of facilitated diabetes education. The implications of this project extend beyond improvements of hemoglobin A1C and demonstrate how evidence-based practice can improve the quality, consistency, and equity of healthcare delivery. At the patient level, standardized interpreter-facilitated diabetes education improved patient understanding and supported more effective diabetes self-management, providing education in the patient's preferred language help reduce communication barriers and promote active patient participation. For nursing practice, this project highlights the importance of role in the advanced practice nurses and leading evidence-based educational improvement initiatives. Standardized diabetes education and consistent utilization of professional interpreter services can reduce practice variation while improving patient education and communication. At the organizational level, the intervention was successfully integrated into routine clinical practice workflow using existing interpreter services and electronic medical resources. This demonstrates that the meaningful improvements in the quality of care can be achieved without requiring significant additional staffing, financial investment, or in organizations that have interpreter services already. In conclusion, this quality improvement initiative demonstrates that standardized interpreter-facilitated diabetes education can significantly improve short-term glycemic control among adults with limited English proficiency. Beyond the clinical outcomes, the project showed that evidence-based, culturally responsive education can be integrated into routine primary care practices using existing organizational resources. If the project is expanded into the future, I would recommend implementations across additional culinary health center locations, evaluation of longer-term hemoglobin A1C outcomes, and the inclusion of more diverse language groups to improve generalizability. I also believe that standardized educational model has the potential applications beyond diabetes management and could be adapted and to support patients with other chronic diseases. Completing this doctorate of nursing practice program has been one of the most meaningful experiences of my professional career. Throughout my career, my primary focus has always provided best possible care for the patient sitting in front of me. Whether working in the emergency department as a nurse, a family nurse practitioner, or a clinical instructor, my goal has always been to make a difference one patient at a time. This DNP journey has extended that perspective. It challenged me to look beyond individual patient encounters and ask how healthcare system, clinical workflows, and evidence-based practice can be improved and positively impact entire patient populations. Through this project, I learned that meaningful change does not always require complex technology or expensive resources. Sometimes improving patient outcomes begins by ensuring patients fully understand their disease and their treatment and their education. This experience strengthened my skills in evidence-based practice, quality improvement, leadership, and implementation of science. More importantly, it reinforced my responsibility as a nurse practitioner to advocate for equitable, patient-centered care and lead initiatives that improve healthcare delivery for vulnerable populations. As I completed this program, I do so with a deeper appreciation for the impact of DNP prepared nurses can have, not only for caring for individual patients, but by improving the systems they care for them. I look forward to continuing to lead equality improvement initiatives throughout my career, using the knowledge I've gained to improve outcomes of patients and the communities I serve. Here's a look at the references that I used for this project. Thank you. This project began with a simple question: how can we better serve patients who cannot fully understand us? Today, I believe the answer is clear. We can remove communication barriers. We don't just improve hemoglobin A1C, we improve trust, understanding, health equity, and ultimately patient lives. Thank you for your time.